Well, hi folks, Bill Kelly here, Colonel U.S. Army retired, professor of medicine. I'm the medicine clerkship director now, and I used to do a pre-clerkship module, a bunch of other stuff. I just wanted to say welcome, and medical school, especially at USU, it's going to be incredible. You're going to be learning all the science, you're going to be practicing clinical skills from your first couple of weeks of medical school on, and you're surrounded by just amazing people and patriots and scholars and faculty are rooting for you. It's going to be great. One way in which people get tripped up, though, is this NBME examination. So we put together this video to help you avoid some of those pitfalls. Look forward to working with you. Stay in touch. And again, I know you can do it. Answering multiple choice questions about patients, clinical vignettes, is as easy as getting a basket. Well, these medical exams are not easy for a lot of people, and some really good, really smart people get tripped up on the multiple choice question format. But I'm going to share with you a method that we've published. It's helped hundreds of people from the level of a second-year medical student up to practicing physicians in different specialties. And the reason we did this is because it was really unsatisfying what was out there already. You can search for test-taking tips and get 100 million suggestions. Some of them have to do with, getting sleep and exercise and maintaining, caffeine levels and things like that, and that's all fine. A lot of it, most of it, is people trying to sell you things that haven't been proven to work and things that you do not need. And then you also get some gimmicks, like the suggestion to always pick C if you have to guess. Now that is bad for a couple reasons. One, it doesn't work because one of the test writer rules is your answer choices have to be in alphabetical order, so you can't hide the correct answer in C anymore. But more importantly, even if it did work, which it doesn't, it doesn't help you be a better clinician, and what we're going to go through helps you work better in the clinic as well as on test day. A few things to say up front. Number one, you have to read. You really have to read. And you have to write out things, not just type things, but write out to encode into your memory. You can't watch med-ed videos. You can't watch just the lectures at 1.5 speed. You can't flip through someone else's Anki deck. You have to really read the stuff and write out things on your own. Second, this method works with clinical vignette questions, not simple recall questions. So if the question is, what's the dose of this drug? What's step 3 of the Krebs cycle? It's not going to help. But fortunately, most questions, most exams these days are moving towards clinical vignette base. Another thing is you have to be well. We want you to be well for you in your life and the people that care about you. We want you to be well because you're our professional colleagues. And any test-taking tips are not going to work. Any remediation is not going to work if you're unwell. Sometimes the things that can trip you up are known as the 7 Ds, and I'll show these here. If any of these things are affecting you, which is actually common, either at baseline or during training, no shame in this. The only shame is in not talking to somebody about it and getting it addressed so you can focus on your studies and be better. So be sure you take care of yourself. And I'm going to throw you right into a question. Let's say it's test day or a practice question here that you're doing. How would you do it? Well, hey, whoa. Were you looking at the answers first? Do not look at the answers first. There's 3 reasons I say that. Number 1, another test writer rule is any question that's a good question, high stakes exam, should be answerable without the choices. But more importantly, you don't want to, what we call, anchor or prematurely close a case. Basically, once you look at the answers, you cannot unsee them and get them out of your brain. So in this example, you're seeing a CT angiogram, thrombolysis answers, so you're thinking, oh, this might have something to do with blood clots. You start reading the question, pleuritic chest pain, prolonged car ride. All right, this was a pulmonary embolism. And you answer that way, and of course, you are wrong. The most important reason to not look at the answers first is this. Your patients do not come to you as multiple choice questions. So if you cover up the answers, you're kind of replicating, it's like a low fidelity simulation, a practice patient with every question that you try to do. So doing this again, let's say we cover up those answers. We're reading the question again. And you note, well, hey, the temperature's kind of high. The guy has sputum, X-ray infiltrates, and a white count of 19,000. Sounds infected. So I'm not going to think pulmonary embolism and blood clot. I'm going to think pneumonia. And then you commit to an answer like you'd have to in real life. I treat for, community-acquired pneumonia, and then you can see if your answer is there. And that reminds me of another test writer's rule. They can make the question as long as they want. Talk about all this stuff, pet birds, trips to the mountains, second cousins with diseases, whatever they want to write. But anything abnormal, like in this case, the X-ray or the white count, has to be part of the answer. That's a rule. Has to be part of the answer. Broadly, what our method has to do with is self-regulated learning. That cycle of forethought, actions, reflections that surround really anything that you want to do well. In this case, answering a test question, but it could be seeing a patient. People who do this naturally are high achievers. And we've also shown that you can teach people to do this who don't do it naturally. And there's a lot of data out there. 90% of a volleyball serve that's good has to do with this method. But it can be like basketball, like I tried to do just then in that video. Starting an IV, pre-science studying, clinical reasoning. You have to go in to your practice question or your studying or whatever you're doing with the strategy. That's the forethought phase. Our strategy has to do with finding the disease script, that story that tells you what the disease is. And then during the performance phase, you know this, you have to get in the zone, tune out distractions, make sure you're following your strategy and determine if it's working or not, kind of thinking about your thinking, also known as metacognitive monitoring. And then at the end, you have to do this reflection phase after you've done the practice question or whatever it is that you're doing. Most people skip this step. Sure, if you get the practice question wrong, you might read why it's wrong, but how often do you stop and think about why you got a question right? And that's what you really need to do. That's called a causal attribution. And then this final thing is, what are you going to look up right now before you move on to the next practice question so that on test day, when you get a similar question, you can nail it. That's an adaptive inference, and I'll come back to that. In our research, we've identified 7 different types of struggling test takers, and again, I'll share that with you at the end. We developed this form, question review form, that'll kind of coach you through these steps. And I'll share this with you at the end. What I want you to do is print off 20 of these, do 20 practice questions with this method using the form, and ultimately your brain gets reprogrammed so you do the method without needing the form anymore. As you're reading the question, you go through steps 1 through 5. You're going to then uncover the answer choices and commit to an answer. And then even then, you're not done. You have to do those other steps, that reflection that I talked about. Let's throw you in here with a clinical vignette question. Again, the answers are covered. I'm just going to go through this here, thinking of the disease script in mind. So 68-year-old, chest pain. Okay, that chest pain could be a lot of things. It's 3 months duration, meaning it's chronic and it's not acute. So I'm not thinking of acute causes of chest pain. Mid-sternal, no radiation. He gets it when he's walking. It goes away with rest. It goes away with nitroglycerin. So it sounds like a cardiac etiology, angina. And then that's the disease kind of script. And then there's always a subtype. In the case of angina, it could be stable angina or unstable angina. But if you don't know that subtype or think about the subtype, that's when you might find yourself narrowing down the choices on a test to 2 and having to guess. So you want to think about subtypes. It's chronic, it's not at rest, it's not progressing, so I'm going to say this is stable angina. He had a heart attack a few years ago. He has some other risk factors. He seems to be on the right medicines, aspirin, beta blocker, cholesterol medicine, nitrates. Physical exam, blood pressure looks a little high to me. Pulse is a little high. Respiration's okay. Lungs are clear. So again, I'm not thinking pneumothorax, heart failure, pneumonia. No extra heart sounds. Other exam is okay. EKG. No ST changes. So it's not acute coronary syndrome. And now, because we've covered the answers, I have to think, what would I do IRL, in real life? So let's say I'm seeing this person in the cardiology clinic or medicine clinic or family medicine. I said it's angina. I said it's stable angina. So I'm not going to whisk him off to the cath lab. It'll probably be medication management. And since I noticed his blood pressure and heart rate was a little high, I'll either increase or add a medicine, and I don't know what dose he's on of metoprolol, but I'll increase that, whatever that is, because I want his blood pressure and heart rate to come down. Now, before we uncover the choices, you have to commit. How confident are you? Scale of 1 to 5, I'm probably a 4. I'm pretty confident that my answer is going to be there. All right, then we do the big reveal, and I look at them. My answer is there, C, increase the metoprolol dosage. And then I can quickly scan the others. That calcium channel blocker, especially diltiazem, is not as good. Ranolazine's another kind of long-acting anti-anginal type medicine. I'd like to do that later. And then I already said I'm not going to take him to the cath lab. Had I read the answers first, I might have take him to the cath lab and then not been able to unsee it and maybe been tricked into thinking this was somehow unstable angina. Now my answer is correct. But again, what are my next 2 steps? Why was I correct? Well, I got the disease script and the subtype, and I recognized that his blood pressure and heart rate were not at goal. That's why I was correct. What am I going to look up? Because even if you get the question right, there's always something to Google for 2 minutes that you need to check before you move on to your next practice question. I might look at ranolazine and learn more about that medicine, refresh my memory. I might look at what's the goal heart rate for a beta blocker? Is it 50, 60? I don't know. I'd look that up. The point is, now at the point of practice questions, you look it up because that's when you're going to remember what you find. Some additional strategies. It's all about retrieval practice. Making your own flashcards, putting stuff in and out of memory repeatedly. Time-space learning. Maybe you're studying about kidney stuff this week. Schedule a time a week from now to do a quiz on the renal stuff. Kind of reinforce your learning. Elaboration. It's about making connections. So as you read about pneumonia, connect what you're reading to the face of a patient you saw with pneumonia and you'll remember it better. And if you haven't had much clinical time, you can connect it with a patient you saw on the pit or the resident or some TV show. Teaching someone else is often the best way to learn. There's a lot of responsibility. You don't want to give your colleague bad information, so you really learn it before you teach them. And avoid the fluency illusion. You might hear a lecture, watch a video, and say, all right, that makes sense, I get it. You do not get it. You have to be able to recall it and work through it later. So don't give yourself the illusion that just because you saw it, that means you know what it is. Interleaving is interesting. You want to read, like the chest pain case, read the disease script for angina, for unstable angina, for pneumothorax, for dissection. Read those presentations together so you can compare and contrast when you see those cases on test day or in real life. And then generation, you want to think about the answers again before you see the choices, because whether you're right or wrong, that process of thinking about it will help you learn the material. And then confidence calibration. It's not unusual if you've had struggles with tests in the past. You've been burned before, your confidence is low, and that can make you change the right answer on test day, and you get tripped up and run out of time. Doing that confidence calibration that's on the form before you see the answer will help reset your internal confidence measures. Of course, you want to be confident when you know the material, and if it's something you don't know, you appropriately don't want to be confident, and this will help you find out which is which. We're going to share a couple of papers, links to videos, the question review form, all that stuff. And also reach out anytime. I'd love to work with you or your institution in the future. It's very gratifying to see good people who are good clinically get to demonstrate that on these high-stakes examinations. But again, remember, you have to put in the time to read, write stuff out. Don't rely on other people's content. You have to encode this in your memory. Rather than burn through 1,000 questions, go through those questions slowly using this method. Use the form the first 20 times you do it, and then the process gets programmed into your brain. Take care of yourself, take care of each other, and I know you can do it. Now, if you practice all of these steps, it really is true that answering a multiple choice question about a patient, a clinical vignette question, is as easy as getting a basket.